on behalf of the League of Women Voters of Seattle-King County and the Seattle Times Mental Health Project, I want to warmly welcome everyone to tonight's event. My name is Heather Kelly, and I'm the president of our local League of Women Voters. We're recording the event, and that recording will be available publicly afterwards. For those who can't see me, I'm a white woman with dirty blonde hair wearing a blouse with green, blue, and white splotches. Any computer users who need closed captioning tonight will see an icon at the bottom of their Zoom screen. You might have to click more in order to see it. And it says show subtitle. So if you click on that, you will be able to see a live transcript of the event. We acknowledge tonight that we occupy the ancestral lands of the Coast Salish peoples, in particular the Tulalip, Snohomish, Stillaguamish, and Sauk-Suatl tribes. We see you, respect your right to sovereignty and self-determination, and are committed to being better listeners, learners, and lifting Indigenous voices. At the League, we like to pair our land acknowledgements with a suggested action. And since Thanksgiving is right around the corner, I highly recommend checking out the Racial Justice Guide to Thanksgiving, produced by the Center for Racial Justice in Education. You'll find that resource in the chat. So a little bit about how tonight came about. Watching our communities grapple with the pandemic and other national and global challenges, the League identified behavioral health and mental health as an area we wanted to understand better. As we began to learn more about it, it led us naturally to examine the behavioral healthcare system here in King County. And we thought that was a really worthy topic for an educational forum. Around the same time that a small work group was formed to plan tonight's event, the Seattle Times Mental Health Project was launched. Based on a mutual interest in the subject, it seemed like the perfect opportunity to come together on this critical issue. And we reached out to the Seattle Mental Health Project editor requesting their involvement, and they were enthusiastic, so here we are. Tonight's forum is called The Behavioral Health System in King County: Challenges, Innovations, and Opportunities in Addressing Mental Health and Substance Use Disorders. There will be an opportunity to ask questions throughout the event, and we'll begin fielding those questions at around 10 after 8. So go ahead and ask your questions as they come to you using the Q&A feature at the bottom of your Zoom window. If you enjoyed tonight's event, mark your calendars for December 2nd, which will be our forum on homelessness, a new approach or more of the same. And on that night, we'll be asking whether an integrated regional approach to homelessness and more funding will provide for better facilities and housing. And now I'd like to introduce our moderator for this evening, Hannah Furfaro. Hannah is a mental health reporter at the Seattle Times. She has a master's degree in science and health journalism from Columbia University and spent several years writing about neuroscience and psychiatry before joining the Times in 2019. Her work has focused on pediatric mental health, psychiatric drugs, new treatments, and rare mental health conditions. And she's published stories in Science, the Wall Street Journal, and the Atlantic. She grew up in Minnesota. Okay, Hannah, take it away.
Hi, good evening. Welcome to a conversation from the League of Women Voters of Seattle-King County and the Seattle Times about the state of behavioral health care in our communities. I want to welcome our panelists, Sharayah Lane, Isabel Jones, Representative Nicole Macri, and Jim Vollendroff. And I want to welcome you, our listeners, especially those joining us from King County, which will be the focus of our conversation tonight. I'm Hannah Furfaro, and I'm a mental health reporter at the Seattle Times. This is the first co-sponsored event from our new mental health reporting team. It launched in September and is dedicated to covering the state's mental health system and solutions that could improve it. In preparation for tonight's conversation and as part of our new reporting team's launch, I've spent hours speaking with mental health providers, policymakers, and people with lived experience. What I've come away with is a picture of a broken system. No matter who you are in the state of Washington, you'd likely face difficulty finding a therapist if you needed one. If you needed a higher level of care, you might struggle to find outpatient options in your community or even an hour's drive from home. For those who need inpatient treatment, it can be tougher still to get a bed. All of these scenarios are made much more difficult if you're a person of color, LGBTQ+, from an immigrant community, if you have public insurance or no insurance at all. If you're on the other side of the fence as a provider, you might be burned out. Demand for behavioral health care is way up since the start of the pandemic. Our systems of care are in many ways outdated and too expensive. A recent national survey, for instance, found that Washington has the 5th highest prevalence of mental illness. Over half of people with a mental illness here don't ever receive treatment. Officials in King County in the state of Washington, though, and advocacy organizations and providers are trying to chart a new path. In 2014, lawmakers passed legislation that moved to integrate behavioral health care into a physical healthcare system. The move recognized that mental health is indeed health. People's well-being shouldn't be thought of as separate by providers or by insurance companies. How this integration has played out differs from county to county. Tonight, we'll dig into the ways King County in particular is approaching this new model of care. We'll also talk about the forthcoming 988 Crisis Lifeline, mental and behavioral health disparities, and challenges in training and retaining our behavioral health providers. I'm really excited to get this conversation going. And so now I'd like to introduce you to our panelists. Sharayah Lane is Acting Program Manager at Philanthropy Northwest, a member of the Lummi Nation, and brings lived experience to this conversation. Jim Vollendroff is Behavioral Health Senior Advisor for Policy and Advocacy for the Department of Psychiatry and Behavioral Sciences at the University of Washington, and he also brings lived experience. Representative Nicole Macri is State Representative for the 43rd Legislative District and also serves as Deputy Director for Strategy at the Downtown Emergency Services Center. And Isabel Jones is Deputy Director of Behavioral Health for King County. We've got a lot to get through, so I'm going to start this conversation by directing each question to one panelist, but I'll ask the rest of you to chime in throughout the conversation. Isabel, let's start with you. I'm hoping you can start by describing the ways that King County's transition to integrated healthcare has played out a bit differently from other counties, and give an example or two of how someone seeking behavioral health care might find it different now than a few years ago.
Yeah, thank you so much for that question, and thank you for including me in this event. So over the last 5 years, the state has undergone a significant transformation in terms of how Medicaid behavioral health services are paid for and managed. And when I say the word behavioral health, I want the audience to know I'm referring to mental health and substance use disorder. Behavioral health is a term that refers to both mental health and substance use disorder conditions or treatment. Before 2016, the mental health, substance use disorder, and physical health delivery systems operated in a way that was very fragmented. The counties were managing the mental health system, the state was managing the substance use disorder system, and Medicaid health insurance companies were managing physical health or medical services. So you might be wondering how the way the services are paid for actually impacts clients. And I think from the perspective of a Medicaid client, they really did feel this fragmentation and these silos every day as people sought to access care. If a client contacted their insurance plan for help finding a provider, that plan could only help them with their medical needs. They would have to navigate 2 different systems to try to get access to mental health or substance use disorder treatment. So the state wanted to make a change to move towards more whole person care and the ability to treat both the mind and body. Over the last few years, I think a lot has changed and some of these barriers have started to come down. Mental health and substance use disorder and physical health are now all under the umbrella and responsibility of a client's insurance plan. And those plans have to have broad networks that can address all needs and coordinate care across all types of services. We've also seen, particularly with behavioral health, so substance use disorder and mental health, we've seen a lot more cross-training of clinicians. For the first time, I think in 2016, people could actually go to a co-occurring visit where they could have mental health and substance use disorder addressed together in one visit. So we're certainly seeing progress. And with respect to how King County is doing this differently, the simplest way I can try to describe it is the county has a unique public-private partnership with both the Medicaid health plans as well as the behavioral health providers. And for us in King County, full integration really goes beyond just behavioral health and physical health. It also means bringing in those social determinants such as housing, transportation, employment, many of the social services that we know are so important to people having good outcomes and that we know the county is often the funder for. So we are managing behavioral health as more of kind of a countywide system with the county still in a leadership role and also bringing in a lot of those social services to go beyond just physical and behavioral health.
Representative Macri, as someone who plays a statewide and a local role, can you talk about some of the deficiencies that you continue to see, especially within the community-based mental health system?
Yeah, thanks for that, Hannah. And thanks, Isabel, for that really helpful overview of the system. And as you mentioned, Hannah, I work both as a provider in the system as Deputy Director at DESC, and in my legislative work really do focus significantly on behavioral health policy and budget investments. And I would say before the pandemic, our community-based system was stretched. It's under-resourced, and it can be difficult at times for people to get sustained, timely care. But I want to underscore now, as we've been through this pandemic going on, I think 20 months now, that this under-resourced system has really struggled to respond to a dramatic increase in behavioral health needs across the region. And that cuts across income levels and ages, race, and all demographics. We're seeing folks who are struggling with behavioral health care needs who are seeking care for the first time and struggling to find it. The state really focuses most significantly on the low income population, since the state is responsible for the Medicaid public health insurance program, but is also very active in ensuring just a full capacity for the healthcare system in general, be it if people have private insurance or not. And I think some of the deficiencies we are seeing now that have been exacerbated during the pandemic is that it's become clear that we have too many people who are struggling with behavioral health conditions who don't have places to be safe. So that could include long-term stable housing. We've obviously seen increases in the rates of homelessness through the pandemic. But also we are hearing from our Children and Youth Behavioral Health Task Force that one of the biggest needs are for stable places when young people are coming out of outpatient care. We know that for people who are housed or unhoused, when they experience acute crisis, there are not enough places for folks to go, be it inpatient care in a hospital or a crisis stabilization center where they can get short-term care. So places where people can go, I think, is something that many of us in the behavioral health system are really coalescing around, and how can we expand that? Some of the things that you touched on remain deficiencies. Racial disparities in terms of access to care and culturally appropriate care are definitely huge. And as I think we'll probably hit on during this conversation, just the struggles to attract and keep people in the profession all across the career ladder, from peer providers, people with lived experience providing care, to master's level social workers, to advanced practice nurses and psychiatrists. We have a workforce shortage in behavioral health, and that's been growing over years, but has really hit a crisis point. So we're at a point where many policymakers at the state level are talking about the need for a dramatic shoring up of the behavioral healthcare system.
And Jim, I want to jump straight over to you because I know that you also have a lot of thoughts about deficiencies.
Yeah, thank you so much. And again, I want to thank the League of Women Voters for putting this on, and the panelists who are participating tonight. Everything that's been said so far, I think, is extremely important. And, you know, one of the things that I like to describe in terms of the challenges in our system is that I like to think of our system as, you know, we don't really have a mental health system. What we have is a mental illness system. And what I mean by that is we oftentimes wait until people are so ill with their substance use disorder or their mental illness before we provide treatment. And what we're beginning to see is shifts in that. And we're going to talk later about 9 988 and, the crisis delivery system, so that we can actually reach people earlier and not have people deteriorate to the point where they need hospitalization. The workforce crisis that Representative Macri mentioned, I think is real, and we're going to talk more about that. The other thing that I'd like to point out is, youth and young adults are a population that we are not serving as well as we could either, in addition to BIPOC communities and LGBTQIA plus communities. So the health disparities, in addition, cover multiple populations. And I'll talk a little bit about that later, because we also have rural areas of this state that are not served well. But I also want to point out that in 2008, when we had the economic downturn, our budgets were significantly cut. And it's only been in the last 5 years that we're back at the same budget levels that we were for behavioral health in 2008. So the legislature in the last few years in particular has really responded with new investments that will hopefully help continue to turn the tide on some of these challenges.
Thanks, Jim. Sharayah, I'd like to turn to you now, because you're joining this conversation as someone who has sought care from various social service organizations. I'm wondering if you can tell us a little bit about how you came to look for care, but also how you think, what you think would help people who've been in situations that are similar to the ones that you've experienced.
Yeah. First, let me start with a greeting in my language. Now at CM and Ischalacha, which means hello, my friends and relatives. My name is Sharayah Lane. I am a member of the Lummi Nation on my mother's side, and also an American descendant of slavery on my father's side. And, that greeting I would like to use as an opportunity as well to ground our conversation. When I say hello to my friends and relatives, I think it's really important for us to stay grounded in the understanding that I don't know that there's anybody on this call who is not directly linked to somebody who has experienced these issues, and to really see and understand what we're talking about in that relational, from that relational lens. So a little bit about my background. I was born in Seattle, but moved up to the reservation at a pretty young age as a result of the Indian Child Welfare Act. So my mom was in Seattle and was told that if she didn't get my sister and I with a family member, that we were going to be adopted out and she wouldn't see us again. And so growing up on the reservation came with, challenges of its own. I moved to Seattle really in search of opportunities, like many Native people do who are coming from reservation lands, opportunities that weren't available to me where I was coming from. And so being in search of a better life, for lack of a better way to put it, included, showing up and needing to navigate these systems and these organizations to try to find the help that I was looking for at that time. And in addition to trying to navigate these systems, it comes with the sort of weight of systemic and structural racism, historical and generational trauma, and all these things sort of added on top of that. And so, thankfully, there were some really incredible programs that I was able to find after coming to the King County area that really guided my journey at that time. And I think one of the most important things to consider when looking to help people in similar situations is, as we're having these conversations, to really systemically integrate lived experience. So I think it's great to have voices like mine on a panel like this, and to keep that practice going, and to do so in an authentic way. That's not looking for people's stories of lived experience as a way to sort of gain inspiration or to just have that voice at the table, but to really, really listen to people who know what they're talking about, people who have lived through these challenges and who have navigated these issues, and to really integrate the solutions that can be brought forward through lived experience. Also, as somebody mentioned before, culturally competent solutions. So one of the most important steps in my own journey was being able to access resources that were specific to Native people through Native American-led organizations that were at times the only way that I was able to get connected. For example, having a DSHS worker at the Chief Seattle Club that was there for a couple of hours every day, where I could go into an environment, talk to somebody, do an assessment, get the resources in an environment and in a setting that was safe and that was accessible to someone like myself, who was a homeless Native American person at that time. I could go on, but I'll go ahead and turn it back over.
Sharayah, can you talk a little bit about what racial equity would look like in the behavioral healthcare system or a community care environment?
Yeah, I mean, I think that there is so much to learn from Native American organizations in King County. There's some really incredible models and examples to draw from that can be replicated and applied to other groups of color. The Seattle Indian Health Board has some really incredible practices. The Chief Seattle Club has been doing really amazing work for a long time. And these are things that I would hope are not just available to Native people, but particularly available to Black people as well. And so I really appreciate the BIPOC acronym that's taken hold over the last couple of years, not just because it so well describes my identity, but also because it is very explicit and specific. So my interpretation of it when it first came out was this understanding that there are some of the most horrific, heartbreaking, and unjust statistics across this country and across our communities that are reserved for Black and Native people. So being really, really specific about that, and being really explicit about that. Go ahead, Jim.
Well, if I could just tag along. So thank you so much for that comment. I think the other thing I think that's incredibly important in this conversation is that we need to make sure that these services are available, not just in urban areas, but in remote and rural areas of Washington state equally. We've done a lot of focus groups with individuals in recovery as we've been doing the 988 work. And one of the things we continuously hear is that we don't have a system where there's equitable access, and disparities are about access and outcomes. And so those two things together are the things that we need to address to make sure that we're providing services to all of our communities in Washington state.
And I want to dig in on that a little bit more. You made an interesting comment earlier that we don't have a mental health care system, we have a mental illness system. And I'm wondering if you can talk about the ways that this system, however we want to think about it, has been built to exclude or keep people from accessing quality care, because in some ways, it might not be an accident that we see some of these disparities. And I wonder if you could speak to that.
Yeah, I think first of all, I'd like to say that I think we have an incredible provider network in Washington state that does the very best given the set of laws that we have in place, the requirements we have in place, the reimbursement that we have, the pay. So I think I want to just, again, give a shout out to providers who I think do incredible work every single day to attempt to meet the demand. But the demand is increasing. You know, one thing, Hannah, when we first started that I forgot to mention was overdose deaths. And the incredible number of overdose deaths that we've seen, particularly related to fentanyl in the last couple of years, is staggering. And so we're losing an incredible large number of individuals. And I think part of it stems from the fact that we have a system that, this is the simplest way to put it, is kind of cookie cutter in some ways, because we have laws that you have to do certain things. And so in an attempt to follow all the regulations, it's hard to set up a system where you're also at the same time looking at the needs of geriatric populations and youth and young adults and people living with traumatic brain injuries. And so it just gets very, very complicated. And I think that we're at a point in time where we're recognizing that if we don't do that, we're just going to continue to see some of the challenges in our system. And so with the 988 work and with some of the work that I'm seeing related to youth and young adults, I think that we're beginning to understand that we've really got to tailor our programs to meet the needs of individuals, based on, things like, age and gender and income and location, etc.
Thanks. Isabel, I'm wondering if you can talk a little bit about how the county is working to tackle some of these problems, in particular, the community navigator programs and referral systems. Can you tell us a little bit about what those look like and how they're being improved?
Yeah, thanks. Absolutely. And I do want to just add something to what Jim said. I also think, one of the major challenges with the publicly funded behavioral health system and community behavioral health system that we're talking about today is that it's been chronically underfunded, not just in Washington state, but around the entire country. And, for the most part, community behavioral health, unlike other medical systems, is almost entirely reliant on Medicaid funding, which is intended to be a payer of last resort and is always sort of the lowest level funding source. I think it shows that behavioral health in general has been undervalued in our country, and we haven't invested in it the same way that we have other parts of our healthcare system. And until we can really step up and make a significant investment in behavioral health, we're going to have a challenge overcoming some of the deficiencies that Jim was describing. So that being said, we do have some things that we are certainly excited about here in King County. And Hannah, you asked specifically about the Recovery Navigator program, which I can touch on. So this is something new that was established by the legislature last year and has been funded. I will say we're still in the planning and design phase on this program now, so it has not launched yet, but it will sometime next year. And this particular program is one that's designed to proactively reach out to individuals with substance use disorder needs. I think a theme that you'll see from King County more so over the next year is having more mobile services that are in the community, really meeting people where they are, rather than office-based treatment models. And that's what the Recovery Navigator program is. This is a community-based mobile program focused on people who are not currently engaged in substance use disorder treatment, but perhaps have had an intersection with law enforcement, for example, due to simple drug possession. And Recovery Navigators, we are hoping certainly to leverage peers and people with lived experience in this model. But this will be a rapid response model where people are out in the community, connecting with folks to help talk with them about whether they might be ready to engage in treatment, what that would look like, helping them actually navigate the system to find the right provider, get into an appointment with the provider, and actually do a warm handoff into the outpatient treatment system with someone. This will be able to take law enforcement, community-based referrals, family referrals, and it's also something where there'll be case management to stay with someone for a much longer period of time in terms of a relationship, if that's what they need to support them engaging in the treatment system. And that's just one example. We have a number of other mobile teams that we're standing up. I mentioned the importance of integration with housing, for example, earlier, and we are working through our Health Through Housing initiative to make sure that we're going to have behavioral health services on site or on a mobile basis, serving some of our new permanent supportive housing sites. So those are just a few examples.
Thanks. Yeah, I think a number of the things you're talking about get at one of the main threads of this conversation, which is access. And certainly one big piece of that is having a strong mental health workforce. So I'd like to turn the conversation now and talk a bit about that. Jim, I know that you've spent a lot of time on this big issue professionally. I read a statistic from the Mental Health America report recently, and it said that only 12% of Washingtonians live in corner of the state where they could actually have their healthcare needs met. And a big part of that has to do with a serious workforce shortage. So I'm wondering if you can tell us a little bit about some of the challenges that you've seen in training and recruiting and also retaining mental health providers.
Yeah, thank you. It's a great question, and it's a major challenge. And you're going to hear a reoccurring theme throughout the evening, and that is funding. And one of the challenges is reimbursement rates and what we're able to pay clinicians who come into this field. One of the other things that I do is I teach in the School of Social Work at the University of Washington. And in working with students, I hear them constantly going into work in the public behavioral health system and quickly burning out and changing jobs and having a really difficult time, staying in that system. And it has to do with some of the, caseloads and the reimbursement and the hours. And so there's just a lot of challenges in the system. There's a lot of work happening right now in the state, however, to help address that. And I think that there's some potential good solutions happening. The Workforce Training and Education Coordinating Board here in Washington has, at the request of the legislature, has been really doing a lot of work on this particular area. And they've been looking at reimbursement and incentives for supervision of clinicians. They've been looking at the requirements related to supervision and competency-based training, and looking at, are there different ways for us to credential people based on competencies versus everybody needing to have a bachelor's or a master's degree. Sharayah mentioned peers. I personally believe that peers are one of the most underutilized components of our workforce and have one of the highest potential on return on investment. And when I talk about peers and return on investment, I'm not talking about a labor pool that's inexpensive because they're not educated. I'm talking about the return on investment because they're helping people stay out of hospitals and we're not having to pay for some of these higher end costly services. There's work happening regarding reciprocity and interstate agreements, and looking at, if I'm a clinician right now, if I'm credentialed in another state and come to Washington State, I don't get to just start practicing, even if I've been practicing in another state for 20 years. So we're looking at, some reciprocity and some changes there. The Bomber Group made some incredible investments, and I just need to give a shout out to the Bombers for their investments in behavioral health, and two in particular that I want to mention. One of them is related to a bachelor's level program for clinicians so that we can have more bachelor's level clinicians in the workforce. There are many, many young people who go into the college and get a degree in psychology. And sometimes it's hard to match them with the workforce, and we're trying to change that. So if you go and you get a degree in sociology or psychology, that we can put you in a position that will benefit the workforce. The other is investments in an apprenticeship program. I'm a strong believer in lived experience. I too have lived experience. I actually have been hospitalized in the very system that I oversaw at King County when I was there, and bringing the personal background and my lived experience was incredibly helpful. And if we could tap more into that through apprenticeship programs and give individuals credit for their lived experience as they're getting their degrees, we think that could be extremely helpful. So I just think there's a lot of great things happening right now. I'll close with just the fact that the other important thing about workforce, and we've been talking about health disparities, is we do not have a diverse workforce. And that's another challenge. And as an individual who is a member of the LGBTQ community, if I need services, I want to go to a provider that I know understands my community. And every person in this state should have that right. And right now, that is just not the case. And so we've got to do more in that regard as well.
There's a lot to unpack there, and a few pieces that you mentioned in particular, insurance reimbursement rates. I want to direct a question to you, Representative Macri, about that. And then Sharayah, I want to follow up and talk a little bit about the peer model. So first, insurance reimbursement rates. This is a very serious and important topic. Nearly every therapist who I've talked to for the stories that I've been working on have told me the rates that they're reimbursed, and some of them can't because they're held to confidentiality agreements by insurance companies. When I call insurance companies trying to figure out how much will you pay a therapist for an hour of their time, they won't tell me. There's very little transparency about how much therapists are able to take home. But from these conversations, one thing that I've learned is that oftentimes it's very little. And these are people who oftentimes also have significant loans, for these type of training programs that are often really expensive that you all have mentioned. Representative Macri, I'm wondering, what would it take to move the needle on a fundamental challenge like that, just paying this workforce in a way that allows them to stay in it?
Yeah, that is something we really need to work on. And as Isabel mentioned, this is an area of healthcare that's disproportionately financed through Medicaid, which is public insurance for low-income people. And the state has pretty direct responsibility for setting those Medicaid rates. They are vetted, by federal regulation, but it is something that the state can and I think should increase. The complications of the American healthcare system adds to some of the challenges because the commercial payers, the private health insurance companies, as you're suggesting, they have a lot of leverage with therapists in individual providers and how they negotiate rates. And I hear more and more from private practice therapists that they don't take insurance, right? They'll just take private pay. And that is quite a challenge for a number of people who are not able to write a large check every time they go to see a therapist. But on the Medicaid side, we are currently the state healthcare authority is doing an analysis around behavioral healthcare rates. This is the first time we've ever done this to help get a better sense of what the rates are. And I think that will help inform policymakers about where we should head. We know that we are significantly underfunded, in part because we know that services are closing, have closed through the pandemic. And we know that we have more openings in behavioral health organizations than we've ever seen before. What we need to move the needle, I think, is to hear more about where those gaps are in the system to really compel policymakers to understand the urgency of this issue. Sharayah talked about not just including people with lived experience to hear their stories for inspiration, but to really level the playing field and for the system design to be informed by people's experience, so we can really build a system that responds to the varied needs of people across King County and across the state. One of the recommendations that the state's Children and Youth Behavioral Health Task Force has is to provide tangible support, stipends, transportation, et cetera, for people with lived experiences to be involved in the multiple commissions and advisory groups that we have throughout the state, both at the local level and at the state level, which really informs some of these system design changes that you've heard about today. And so I think that is one aspect, is really hearing more from people who are trying to seek care in the system, what's not working. That will help move the needle on more investments, because it becomes pretty clear when you talk to folks that the resources aren't there. Similarly, hearing from frontline workers about their experience, the stressors of the job, and what is missing. And some of that is policy level regulation that makes it difficult to do the work, but a lot of it is around funding and resources. And I've seen I think we need to get more sophisticated in our advocacy in behavioral health and really see these partnerships of people who have been living with behavioral health conditions, their family members, the frontline workers, the organizational administrators, all working together to really get a message to policymakers. What I found as a state lawmaker is that the state's attention is really pulled to the things that the state is most directly responsible for, like running our state psychiatric hospitals. And that is such a narrow piece of the behavioral health system, and the community-based system that is heavily funded by the state, but mostly administered at the local level, is something that we need to draw the state's attention to. And I think that's happening right now, in part because it is apparent that the system is in crisis. We are getting calls from small business owners across the state about concerns about people in crisis in the business districts. We're getting calls from landlords about tenants they have who are in behavioral health crisis and they don't know how to get their tenants help. We obviously see a growing number of folks who are unhoused. We're hearing from educators, teachers in the schools that students are really, really struggling. And so across the board, lawmakers are hearing from constituents about the challenges, but we need to sustain that engagement and not just hear the cry when the system gets to this acute crisis point. And I think that will help us. So I am, as Jim said, the legislature has taken many steps, but we are really climbing out of a very deep hole that was created during the last Great Recession. I think we are poised to take some large steps in the coming years as well, with a particular focus on the community-based system and not just on the state hospitals and only on the inpatient beds, but the full range of services, from outpatient services to the kind of specialty mobile teams that Isabel is talking about. So I think the needle is moving, but what I have found in my role is that advocacy really works, and hearing from people who are most impacted by the system deficiencies is what really moves legislators.
And I think certainly with the rollout of the 988, that need or the hole in services might become even more apparent more quickly as people are seeking out care. We'll get to the 988 briefly, but before we do that, Sharayah, I was wondering if you could talk a little bit about the peer model. This idea has come up a number of times. I'm not sure if anyone's fully defined it, but if you could either talk about your experiences with the peer model or what that looked like, but more importantly, what some of your takeaways were for the effectiveness of that model.
Yeah, I mean, to take a quote out of the book of Alcoholics Anonymous, most good ideas are simple, and when we're talking about human beings who are battling with substance use disorder, who are battling with mental health challenges, that understanding that people want to get well, like starting from that place, that there is this inherent desire in a human being to want to be able to get better. Now, when you come up against this system, this very, very complex, complicated system that we're talking about, and the finances and all the moving pieces of it, bringing it back to the most basic level of human connection. I know for myself that the people who have made the biggest differences in my life are the people who I could sit across from and say, I have been where you've been. I know where you're coming from. You don't even have to say anything because I know. And on the flip side of that, have sat in many offices and many a conversation with people who do not have that experience, and you get nowhere. It's not an honest conversation. It's not a mutually sort of beneficial situation. I mean, I've sat across from people and said, you're getting paid to be here, so let's just not waste our time. and that's it's just the most basic level. I don't know how else to put it, but if you're getting that support or that guidance and encouragement from somebody who just gets it and who genuinely cares about your well-being because they've been there, there's no real way to quantify that, but that's the single most powerful thing that I've seen time and time again. It's something that I've had the opportunity to do with other people as well. And I've seen the peer model be more effective than, somebody with multiple degrees and language and education approaches, where somebody could it's when you look at recovery, it's one of the premises of 12-step recovery, that you can gain the confidence of somebody in 5 minutes, who spent years in sort of psychiatrist offices and all these spaces where you just aren't going to get anywhere. So yeah, I can't say enough about the peer model, and that reaches across all demographics and all lines. Even if you're not talking about substance use, but somebody with a very specific mental health challenge. And if you can come across somebody who's found a way to overcome, or who's found a way to maintain with the struggles that they have, that is invaluable. So I know that there's been an increase and a sort of uptick in peer coaching and different things like that, and getting people more involved. And we've heard a lot of that tonight, but I just can't say enough about it.
If I could follow up to something that Sharayah said that I think was incredibly powerful to me anyway, and that was that people have the inherent desire to get well. And what I say is, I think that people have people who are living with behavioral health conditions, whether it's be substance use disorder or mental illness, have immense capacity to get well, given the right set of circumstances. And that's what our role is in public policy, in healthcare, in government, is to create an environment where they have the tools and resources to get well. And, I've done a lot of focus groups with people in recovery. And what I hear oftentimes is things like the recovery support services, the housing, the, job opportunities, peer coaching, all of those kind of things. Evidence-based practices are incredibly important, and motivational intervention and DB, all of those things are important. But when you ask people what it is, it's that connection, and it's those recovery support services that help move people into recovery. Last night I was involved in a focus group related to 988, and I asked a group of people with lived experience. I was facilitating a group of about 10 people in recovery. What would a new system look like if we were successful in implementing this new 988 system? And I heard things like, well, we would leave the system less traumatized than when we entered, implying that they're leaving the system more traumatized than when they entered. So we've just got a lot of work to do. And I think people with lived experience are an incredible part of that answer.
Thanks. Yeah, I'd like to transition now actually and talk a little bit about the 988. So in the middle of next year, crisis line for suicide prevention and other crises will go live. The idea is that this number will be easy to remember, and it can serve as an alternative to dialing 911 and ushering in an armed police response. I know that we've talked about this a little bit, but I'm hoping we can dig in. And Isabel, I'm wondering if we can jump over to you. If you can talk a little bit about some of the new services that the county is hoping to stand up, or that's standing up right now in support of people who dial 988.
Yeah, absolutely. Thank you so much for asking about this. So I just want to start on this topic by commending the legislature and how they've been thinking about 988 for Washington State. As you mentioned, Hannah, at the federal level, 988 is really kind of a basic requirement. It's moving the suicide prevention hotline, the National Suicide Lifeline number, which is a standard 10 digits, to a 3-digit number that's much easier to remember and easier to access. Washington wanted to use this opportunity to go beyond kind of the basic requirements. And the legislature passed a bill last year to implement 988 that envisions using 988 as a crisis call center hub, kind of an air traffic control for all things behavioral health crisis that is going to go beyond just suicide prevention phone calls. So we think this is a great model, and certainly commend the legislature in thinking big. But I also do think I want to set expectations about how much expansion of our community-based crisis response system needs to happen in order to bring this type of vision to reality. Just as an example for comparison, there's about 7,000 fire and police responders in the King County region. And there are about 80 mobile behavioral health crisis responders who are covering King County on a 24/7 basis. That includes the 50 designated crisis responders who are primarily working on involuntary commitments. I think we have around 38 or 40 mobile behavioral health crisis responders. So we have a long way that we need to go in terms of being able to expand our crisis response system and being able to make sure, as I think we all want for our community, that we can have the appropriate response for sort of the appropriate event that's happening in the community. So in terms of our vision for 988 implementation, it's really to focus the resources and energy on addressing the community-based gaps. Just to give you a few examples of what we're thinking about, King County has already been able to secure funding through the legislature to stand up 2 crisis stabilization facilities. These are going to be specialized non-hospital facilities that people can go to or be brought to if they're experiencing a behavioral health crisis. They'll be able to stay for up to 14 days to get stabilized. This is a level of care that we don't have right now anywhere in King County. So bringing online, we still need to build these facilities, but bringing online 2 is going to be great for our community. We're also working on significantly expanding access to next day appointments, which allow people who otherwise would go to the hospital to get an appointment the very next morning with a mental health or substance use professional. We have about 2,400 of these appointments available per year, and we think we're going to need to more than double that likely to really meet the need, especially in response to 988. And then we're also envisioning a significant expansion of mobile crisis outreach. And I already gave a few examples of different mobile programs that we're standing up, but just in terms of basic kind of mobile behavioral health crisis outreach that can be deployed by this air traffic control 988 call center. We think we probably need to at least double our current capacity, both for youth and adults, especially not just, again, in response to demand from 988, but to make sure that we're having the right kind of response to the right event that's happening. And then the last thing that I would say is just we are also very much wanting to integrate more peers, especially into crisis response. Even that Recovery Navigator program I was talking about earlier, what better than to have a peer who has navigated the system themselves, be the person who's actually engaging with someone, telling their own story of recovery so someone could understand what that might look like for them if they decide to engage in treatment. And then again, being there to really help them navigate how to move through the system. So that's another priority just in terms of building up our crisis response system.
I want to jump to Sharayah, but actually just before that, Isabel, I want to follow up with you. You said a number of things that kind of struck me just in terms of the amount of scaling up that you need to do. So when you say you need to double a lot of these units, that seems like a tall order. And I do wonder, are the resources there to get that up and running by next summer?
Yeah, those are great questions. Some of the things I mentioned, like the crisis stabilization facilities funding has been allocated by the state for those next day appointments. We have worked to secure some local funding already to expand those. On mobile crisis outreach response, I think we still are going to need to work to identify additional funding. And that's something we may be talking with the legislature about this coming session. But as Representative Macri said, I do think there's an understanding at the state level. It seems that we really have to invest in this if we want to, be able to have the outcomes in the system that we want. So.
Hannah, I have something to add real quick. Just a couple of reminders that in the end of 2000, the voters of King County passed a large bond at Harborview Medical Center, which included a new behavioral health tower at the Harborview site. And in that facility is going to be a crisis urgent care walk-in clinic to meet the needs of people before they need hospitalization and to divert people from potential incarceration. And then the other thing is the legislature funded a new behavioral health teaching facility on the grounds of Northwest Hospital, UW's Northwest Hospital campus. And that will allow for the local treatment of individuals who need longer term psychiatric inpatient so they don't have to go down to Western State Hospital. That allows us to do better treatment in our own community. We shouldn't have to leave our community if we need treatment for behavioral health. So there's other investments that the legislature and the voters of King County have passed that will also help with some of this capacity issues.
Thanks. And thanks for following up, both of you, with some of those additional services and things that are being built out. Sharayah, I know that you wanted to jump in, so I want to give you a chance now.
Yeah, I know I touched on this earlier and just wanted to reiterate, especially when we're talking about things like crisis intervention, is the explicit focus on racial equity. I mean, I don't even know if racial equity is the right term, but I think about, you know, the statistics of Native American disproportionate statistics of suicide. You know, I think about the tragedy in Seattle of Charlena Lyles, who was killed by Seattle police on a call that you know, had to do with behavioral health. And so topics of DEI and racial equity are very important, but I believe not this is the most important place to be extremely specific and explicit about how we are integrating race and culture into these programs and into these conversations, because it literally could mean life and death for somebody if there is integration of a racial justice lens into these programs and how they're being rolled out in crisis response for communities of color. Having somebody that shows up that looks like you, talks like you, comes from where you come from, could literally mean life and death. So I just want to continue to encourage us to lean into the explicit acknowledgement and integration of race into these programs and into these conversations.
If I can add on to that, I think, Sharayah, that's such an important point, and we can't ignore the point earlier that there is great disparity in the workforce now. There's not equity in terms of who are trained behavioral health workers and who are people seeking behavioral health care. And in my work at DESC, DESC is the contracted provider to King County for this adult mobile crisis response team that works countywide. And we've been talking more and more about how the crisis response system needs to create more deliberate partnerships with community-based organizations that may not be licensed behavioral health organizations, but have those social connections to people and may provide the more relevant kinds of supports for folks than the mental health treatment. Not to minimize the treatment and care that people need from the behavioral health system, but as Isabel talked about at the outset, this sort of connection, not just to like primary care or physical health care, but real connection to the kinds of supports and services that that determine people's well-being, and as you say, can be life or death determinants. And so there has been a lot of conversation among behavioral health providers, and particularly those who are working in the crisis response system, about how we can more deliberately enhance those connections. And at the state level, the legislature has really been focusing on the role that BIPOC-led community-based organizations in particular can and should have, and how the state can help support the capacity of those typically grassroots smaller organizations. This has been particularly relevant during the pandemic, when we've seen such a disparate impact in terms of job loss and COVID rates among BIPOC community members. And so I appreciate that you raised that point, because I just feel like it's so relevant, and our behavioral health system has a really long way to go in terms of addressing issues of racial equity.
Representative Macri, I want to stick with you. And this next question is certainly related to what we've been discussing and is something we could spend another hour on alone. And unfortunately, we don't have the time this evening, but I'd like to talk briefly about your work at DESC and what the agency is doing now to provide housing for people in crisis and what some of those challenges continue to be.
Yeah, thank you for that question. So DESC is the acronym for the Downtown Emergency Service Center, which is a bit of a misnomer in that DESC provides services throughout the region. As I mentioned, we do crisis response services and a whole array of behavioral health services, including traditional outpatient services, street outreach services, and some specialized services, particularly for people who are unhoused with acute substance use disorders. But what we're most well known for is providing emergency shelter services and permanent supportive housing services. DESC provides about 1,500 apartments across the Seattle region for people who have experienced homelessness and who are living with pretty serious behavioral health conditions and often other really complicated medical conditions. And we are actually building more housing than we've ever been engaged with before, and partnering on this new initiative. Isabel mentioned the Health Through Housing initiative to take hotel properties that the county has purchased and immediately convert them to emergency housing opportunities to bring people inside with robust services on site with a long-term vision to convert that kind of hotel room type emergency housing to actual stable permanent supportive housing by renovating the buildings. And so through the Health Through Housing endeavor and through City of Seattle's push to develop more units of permanent supportive housing ever before, I think we will see in 2022 more units of supportive housing coming online than we've ever seen before. The challenge, of course, is that we have more people who are living with behavioral health conditions who are unhoused. And so that the units we're bringing on won't match. And one of the challenges that is becoming clearer to us through the pandemic is that people's needs are pretty acute, and that more integrated on-site care is needed. So the kind of model like Isabel talked about, where there is mobile behavioral health teams that can visit residential sites like permanent supportive housing, are the kinds of models we're going to need to scale up, I think, in the future. And so there's been emerging conversations, thanks in part to the work of King County, that are happening at the state level on that. But what we have found, DESC has really been a leader both locally and nationally in this model that is sometimes called housing first, where the premise is somebody is homeless. If they have acute conditions that need care, what you should do is provide housing, right? You not provide housing only, but get someone into a stable place, because when you do that and you're able to surround people with services and care and community, a lot of the challenges people experience when they're homeless, health challenges, the acute behavioral health symptoms really start to go away, and people's sense of wellness and community and ability to aspire to do the things that they want to do with their lives really begins to take shape. And so it's been good to see the scaling up, but we have a long way to go on that. And the Health Through Housing initiative, I think, is the boldest initiative we've seen ever, with this vision to quickly stand up 1,600 units with just under 900 units already acquired. The county exec announced the opening of the first Health Through Housing units last week. So the purchases happened throughout the summer and fall, and the first units opened up in Seattle at a site that DESC is operating off of Aurora in North Seattle. And so I think we'll continue to see the opening of units, which will be quite helpful, but we certainly have a long way to go to meet the demand.
Thank you. And for listeners who are interested in learning more about some of the topics that Representative Macri discussed and further coverage about homelessness in Seattle, the Seattle Times has a reporting team called Project Homeless that's dedicated to these topics. So if you visit seattletimes.com, you can look for stories there. And my colleagues on that reporting team recently held a series of debates with in advance of the recent election with many of the candidates, some of which who are now elected public officials on, again, some of these topics. So I want to stick with this conversation, though, just briefly about housing and behavioral health as we now turn to the portion of our conversation where we take listener questions. So our first question is from a nurse at a Swedish hospital who asks, what services are provided for folks with substance use disorder or mental health concern who are homeless, especially pregnant women? And so this nurse is saying that they're seeing an increase in the number of pregnant women who are coming in and delivering. And so they're offered treatment suddenly as a patient in delivery. But this nurse thinks that treatment should be available much sooner than that. And so they're wondering what kind of services folks can get. And so maybe Isabel, I mean, anyone can chime in here if you have an answer, but I'm thinking maybe Isabel and Representative Macri, if you want to speak up. Thanks.
Yeah, sure. I can start that question. There actually are specialized treatment. I believe it's residential treatment that's for pregnant and parenting women, specialized providers that do treat that population. We do not have within the geographic boundary of King County right now, they're called PPW programs, a PPW program, but we do have access to nearby providers who have beds that are available, and King County residents are able to access pregnant and parenting women beds all around the state. So that is certainly something just in terms of getting access to that. I mean, if this person is a Medicaid client, they could even contact the King County Behavioral Health Division, our client services line, and we would be able to provide more information to help assist with that. That would be the most sort of specialized treatment for that population. And then, of course, there are other just outpatient programs, residential treatment programs as well, some of which would probably be closer and be in county.
Thanks. Our next question is about stigma. So this person is wondering what experience the panelists have with Nami, which is the National Association of Mental Illness. It's an advocacy organization, and what tools you're aware of that could help lessen the stigma experienced by people experiencing mental illness and substance use conditions.
I can take a stab at that question. Yes, I believe we all are familiar with NAMI, a great organization that does some incredible work with families, particularly related to mental illness. I actually wrote down a list of organizations earlier that I wanted to mention, and NAMI was one of them that help address the issue of stigma. And, you know, I actually like to use discrimination and prejudice as opposed to stigma, because that's really at the end of the day what it is. It's prejudice and discrimination against people living with mental illness and substance use disorders. There's Pure Washington that's doing some amazing work and demonstrating the effectiveness of people in recovery working with people. There's the Recovery Cafe. There's the Washington Recovery Alliance. So there's a lot of groups that are doing, and Representative Macri mentioned earlier, Advocacy, and these are all groups that do incredible work bringing people with lived experience and family members to Olympia and speaking out and participating in forums like this that I think are helping reduce some of the stigma associated with it. The other thing I'll say, in having people like Sharayah and myself who have lived experience and who are willing to come out and say, I'm an individual in recovery, so that we can break down some of those stereotypes and see that people in recovery are your neighbors, your friends, your coworkers, and we thrive in the community just like you do, and we struggle in the community just like you do. And so, you know, we're all I like to say we're all a life event away from a crisis. And so we all have mental health. We don't all live with mental illness, but we do all have mental health. And so just being more open about it and talking about recovery and the fact that people do recover, I think helps reduce some of the stigma.
Thanks. Did anyone else want to chime in on that one?
I mean, I'll go back to what I said earlier about, you know, in bringing people with lived experience to the table, not, you know, not just in the kind of afterthought focus group, but really in driving the governance and design of the system. And so that when the folks who are planning for how these programs, the care system is going to be designed to have the voices of people who have navigated the system, it's so incredibly helpful. We have incredible advocates within Washington State who have really helped to influence how our system is designed. So I think the most recent example you heard is that, you know, we have these planning committees around the 988 crisis response system, and having a focus on people with lived experience being part of those conversations is a priority and something that will help us to build. We have a very anemic crisis response system, and we have a long way to go to make sure when somebody calls 988 in a couple of years, when that phone number goes live, that there actually is a response system that is built behind that telephone number. And it has to be informed by people who have called 911, which is now the option, and have either had their needs met or more often have not had their needs met. So we can design a system that's more responsive to what people actually need. So Nami is an incredibly active organization and has had a lot of influence on the policies that have passed in Washington State.
This question is related, but it's specifically about children. So this person is wondering what agencies have been able to meet the next day appointment demand that Isabel mentioned. This person says, I have colleagues in school-based health centers who are not able to get actively suicidal students seen for intake to an agency for at least a week.
Yeah, so a lot of things I could say on that question. So, you know, part of the issue that we're seeing right now is due to the workforce shortage. It is taking longer at certain agencies for people to get in for an appointment. I think that's due to a combination of workforce shortage as well as a rising demand for services. Even due to COVID-19, we're seeing more people who have, I think, experienced anxiety and isolation, and demand is going up at the same time that workforce is really challenged. And, you know, the Medicaid regulations around going in for an intake appointment, for example, is actually that an agency needs to make an appointment available within 14 days. But it sounds like the example that you're describing is someone who's more in a crisis and has an acute need. We do have right now 4 agencies that are doing next day appointments. I know Navos and Sound Behavioral Health Care are both 2 of them. I, off the top of my head, can't recall the other 2. However, right now it's a relatively narrow population that can get in. They call our existing crisis hotline. We do have, I think this is probably important for people to know, before 988 comes online, we have a crisis hotline right now. It takes about 8,000 calls per month, and it's managed by Crisis Connections. And so the King County Crisis Hotline is one that you can call. That right now is the primary sort of door into the next day appointments. Those appointments are really reserved for people who are in crisis and who otherwise would need to go to the hospital. So that would be a good resource to reach out to look for kind of a hospital diversion option, like it sounds like it's being described. Yeah.
I'd also like to
say that's why we want to greatly expand and open the door on the next day appointments.
Sharayah, go ahead. Thanks.
Yeah, I had a really interesting conversation last year with someone over at the Vera Project, and we were talking about behavioral health and youth, and they were sharing how navigating the pandemic with the young people that they serve has kind of required them to meet their people where they were at and start to develop these sort of behavioral health practices and things that didn't really exist in that same way before young people were experiencing the isolation of the pandemic. And so it just kind of goes back to what Representative Macri was saying about the real value of these community organizations that have deep roots in the demographics that they serve. I mean, I know I've talked about the Chief Seattle Club a lot, 23rd and Cherry Fellowship Hall for the Black community is invaluable. Places like the Vera Project for young people, the Recovery Cafe, and the community that's been built there. I think it's such an untapped resource to really get these nonprofits to the table and learn about what they're doing and even how they've responded recently to the pandemic to really be able to tap into some of those spaces as well to help meet the shortage of these more formalized environments that people may have a hard time accessing, and seeing if there's more ways to work together and to partner with people who have been doing it really well for a long time to sort of spread the load and also integrate more of the community in what we're talking about.
Yeah, and if I could just add to that, philanthropy this is a great opportunity for philanthropy to get involved, and philanthropy has come to the table in some pretty significant ways. We just recently received some funding from Morgan Stanley to actually stand up what we're calling gathering spaces for young people. And the idea is, just like we've integrated physical and behavioral health care, we want to integrate behavioral health into large settings or organizations that are not traditionally behavioral health organizations, so that we can take behavioral health and meet people's needs earlier so that they don't need to get into deeper end or more formal treatment. And so I think just being innovative and, really thinking about how do we get ahead of things. And, a good example is, working with an organization like the YMCA or Gay City or any of the places or schools where there's large populations or gatherings of young people, so that we can train other young people how to support each other's behavioral health needs, are incredible opportunities for us to meet the needs given the lack of workforce that Isabel mentioned.
Thanks. That's a nice segue, I think, into something that we've talked about briefly, but I want to talk a little bit about now, which is culturally competent providers. And so one of our listeners asks, what's happening with recruiting and training Spanish speakers and speakers of other languages to the behavioral health field?
I don't know that I can answer that specific question, what's happening. I can say that it's a need. And one of the things that we're doing right now, the legislature funded a behavioral health disparities report that's being completed right now, with the intention of looking at the full continuum of care, from prevention to intervention to treatment and recovery support, and look at what are the gaps in those systems related to things like behavioral health disparities, different populations, et cetera. And what we plan on doing is we're doing a current state a gap analysis, and then some recommendations to the legislature with the intent of suggesting that it might be appropriate to fund a behavioral health disparities center of excellence in the state so that we can really get ahead of and identify what some of the challenges are. I want to quickly just respond to something that Sharayah said earlier related to 988 and the importance of, addressing the racial disparities in crisis systems. And Sharayah, I just want to assure you that that is something that is central to our work. And we're so fortunate that Representative Orwell actually included a Tribal 988 subcommittee and line as part of this work. So there will actually be a 988 tribal line specifically included in this. And we're also acutely aware and trying to develop components of the 988 response that will address the fact that communities of color, by and large, don't like to call 911 given their experience. And so how are we going to convince them to call 988 when, in fact, when they call 911, that sometimes those are not great experiences. And so there's a lot of conversation and work to embed that into our work in the future. So I just wanted to make sure that you were aware of that and that was something we're talking about.
Yeah, and going back to the sort of culturally competent piece, it really, would, I think, pay great dividends to take that approach of looking to these community organizations first, starting there with these programs, initiatives, and efforts, even with something like a Spanish language program. Looking at some of the most longstanding, most effective community-based organizations that are serving Latinx communities and starting there, rather than trying to come in as the state or as the county, but sort of coming behind them and following their lead on a lot of things. Because even with something like 988, if you were trying to get people to trust this new program that's being rolled out, hearing about that from an organization that they've been involved with for several years is going to have a totally different impact than hearing about it from a flyer or from the DSHS office. And so taking that approach of sort of following these organizations and what they're doing and looking at it, from that lens of, it may not be behavioral health, have that title specifically, but if you look at what a lot of these BIPOC-led organizations are doing, that's exactly what they're doing. And it's what they've been doing for a really long time. And so how can that collaboration be stronger? And then taking that cultural humility approach of even letting them take the lead on this, I think would have the greatest impact.
And in addition to trust building, I think accountability will be a big piece. And so I'm wondering what sort of accountability measures will be in place to ensure that 988 is serving communities of color in particular equally well, but especially, Jim, hearing that there are going to be specific 988 lines, I do wonder how that will be monitored and how we can hold, agencies who are supposed to be providing care accountable.
Yeah, that's incredibly important. And the structure of this is there's a steering committee made up of state representatives, Senator Dingra, Representative Orwell, and then state agency representatives. And then there's a committee of individuals, including individuals with lived experience from around the state who are on this crisis committee. And then there's subcommittees. And the questions that you are asking right now around accountability and data, what are the effective elements that we should be monitoring to ensure that we've got an effective crisis system are being grappled with right now. And so I'm going to share a link in the chat that can be maybe shared with listeners who can go. There's a website that talks about what we're doing related to crisis system redesign and how you can be involved. So if you've got suggestions, ideas, you'd like to be involved, I'll share that resource with you. But there's a credentialing and training subcommittee, there's a technology subcommittee, there's a cross systems and crisis. So there's a number of different areas that we're looking at, and quality metrics and outcomes and data elements to monitor quality are certainly a part of it.
I think we have time for one more question. And again, this is another topic that we could spend hours discussing this. Listener is wondering if someone could please discuss the role of involuntary treatment laws in getting people into treatment.
I could make a comment on that, but I don't know that I want to cover the whole thing. What I'll say is that involuntary treatment is an incredibly important part of our system. However, it should be the last resort. There are so many different opportunities to intervene. And you know, there's this tipping point in somebody's life where if we intervene at the right time, we can avoid so much of the trauma that people experience. And so involuntary treatment is definitely a component of our system that is vital and important, both on the substance use disorder side and the mental health side. But my hypothesis would be, if we were to invest more in upfront services and prevention, we would actually save money on the deeper, more costly end of the system and not need that as much. So that's my take on involuntary.
Did anyone else want to address that topic?
I definitely agree with Jim's take on it. It is an essential part of the system. You know, I would say that we see more and more kind of pressure on the, you know, we sometimes call the ITA, the involuntary treatment system, because of the deficiencies we talked about over the last hour or so in the community-based system. So the inroad to behavioral health care is more and more often through the crisis system, be it that most extreme end, which would be the involuntary treatment when someone is in such acute crisis that they are a danger to themselves or others, or have a grave disability, or are encountered by EMTs at hospital emergency departments, having interactions with police, but really what they need is behavioral health care. And so there's these voluntary crisis responders who are going out to assist people. But what would tremendously help is, as I said at the outset, if we had more places for people to be that were stabilizing generally, and if there was an abundance of community-based care that people could access and access in the way that they want to. And so we are building towards that system. We are rebuilding towards that system, but we have a very long way to go. But I think we'll see in the coming few years, and particularly in 2022 and 2023 with the work on the 988 system, some pretty good progress going forward. We can't deny the impact that the pandemic has had in really increasing the need. So we honestly, we can't work fast enough. And so part of my, what I see as my role is really to bring that urgency to the policy conversation. And thankfully, there are a number of legislators who share my perspective that we have to work very urgently to enhance our behavioral health system.
Thanks. I think that's a good place to close. So I want to close by thanking our panelists for joining us this evening. Thank you so much for sharing your experiences and your perspectives. For more reporting from the Seattle Times Mental Health Project, I encourage you to visit our website, which you can reach by scanning that QR code that's on your screen right now. You can also visit seattletimes.com and find our coverage there. If you registered for this event, you'll receive a list of additional resources and a post-event email. So on this next slide, you can also find that list of resources. And again, you can scan those QR codes to get straight to those websites. So thank you again for joining us.